So I'm Cate, Vice President for Research, and I am delighted to welcome you to this Grand Challenge webinar on the Precision Health Initiative and its focus on childhood sarcomas. The Grand Challenges program was launched 5 years ago. It was part of our bicentennial celebration and something the trustees and President McRobbie were committed to both strengthen the university and to give back to the state that has supported us so well over the years. And the idea was to identify some of the critical issues facing Hoosiers and to bring the full weight of the university to bear on those issues, working in partnership with organizations from around the state and around the nation. We have 3 grand challenges, but our first and our biggest is on precision health, a $120 million investment by the university, focusing on some critical health issues facing people in the state of Indiana. And among those critical health issues is, of course, childhood sarcoma. So we did a webinar back in February about triple negative breast cancer, one of the other issues. We turn today to the childhood sarcomas. And I'd like to say we're going to have a 25-minute presentation, lots of Q&A. You will have opportunities to get your questions in. Most people will be introduced sort of in the order in which they appear, and we have an incredible lineup of people today. I just want to say a quick word of welcome to Kelly and Tony Trent, who are here, the parents of Tyler Trent, who their son, who unfortunately they lost to aggressive childhood sarcoma. But Tyler's courage and his participation in our research and their exceptional leadership have not only been incredibly valuable to our work and this grand challenge, but also really extraordinarily important to fighting sarcomas across the state far more broadly. And so welcome, thank you very much for being here. Again, I appreciate the enormous upheaval your life has gone through and the extraordinary good that you have done out of this situation, and we could not be more grateful. But now I want to introduce Dr. Jamie Renbarger. Jamie is one of the co-leaders of the IU Precision Health Initiative, focusing on childhood sarcomas. She's professor of pediatrics in the School of Medicine. She's a pediatric oncologist at the Riley Hospital for Children at IU Health. She's really quite an extraordinary person, and among her many other accomplishments is she was Tyler's doctor. So I'm going to hand it over to you, if I may, Jamie.
Absolutely. Thanks so much, Fred. And thanks to everybody for being here. Again, especially Kelly and Tony and our entire team. I'm just honored and privileged to be a part of this amazing group. You know, Karen, Pollok, and I started working closely together a little over 5 years ago only. Because we saw this great need for finding better ways to treat really aggressive pediatric cancers and specifically sarcomas. It's amazing to see everything that's developed, and that's as a result of a lot of incredible people working together. So again, I'm honored and privileged to be here and looking forward to the conversation.
We now turn to Kelly and Tony. We're excited about your being here, as I said, and really appreciate your sharing your story and your own engagement in this important work.
Thanks for having us. We, when you go through something really difficult and really hard, you don't want to see other families go through hard things. And as the saying goes, when your child gets cancer, you all get cancer in some form. And so we want to do whatever we can as a family to promote this and to encourage other people to get involved for a worthy cause.
Absolutely, yeah, and it's an honor just to, really on behalf of Tyler, to continue to be his voice and carry on the legacy that he desired to do, and to do that through cancer research.
And what a legacy that is too. Now it's my pleasure to introduce Dr. Karen Pollok. Karen is the other co-leader of the IU Precision Health Initiative on childhood sarcomas, associate professor of pediatrics, and she also has an appointment in the Department of Pharmacology and Toxicology at the IU School of Medicine. She has so many other titles and accomplishments. I'm not going to list them. I'm going to just give you a quick chance as well to say a word of introduction too. Karen?
Yes, thanks, Fred. Good to see everyone, and thanks for joining. I'm in the Department of Pediatrics, and I'm a scientist. And so I've had the privilege to work with Dr. Renbarger and her team, and also with Kelly and Tony Trent. And it's really been an incredible experience to be involved in this whole organization. This is one of the very first times that we as a group of scientists in the Wells Center have been able to really critically link up what goes on over in the oncology group with doing research, and doing research that is prioritized by what the oncologists need at this point in time. And so our role in this has been to develop tumor models from patients that are seen at Raleigh Hospital. And Tyler's model was one of the first ones that we developed. And these are models where we can actually study the molecular signature of these tumors and learn a lot about them, and really do experiments to provide rationale long-term for earlier intervention therapies. And so working with Dr. Renbarger and her group, we're able to really start prioritizing what are the most important questions for us to ask in the research laboratory. And Kelly and Tony have visited the lab on several occasions. We can't thank them enough for doing that. I'm not sure if you all are aware of the impact you've had on our staff to meet you and talk with you all about Tyler's journey. And so we continue to work on his model in a big way. We've actually received funding because of data we've generated in his particular model. And as of today, we've actually generated over 40 of these patient-derived xenograft models from kids that are seen and treated at Riley in a lot of the different sarcomas, and also in some other very rare solid tumors that you find in kids. So thanks, I'm great to be here and be involved.
Excellent, thank you. I'm just making sure I'm managing my mute button effectively. So I now want to introduce my very good friend, Dr. Tatiana Foroud. And Tatiana very well could have started today because she is the PI of the IU Grand Challenge Precision Health Initiative, but she just returned from a richly deserved holiday, so we thought we'd give her 10 minutes to get her feet wet before turning to her. She has many titles: Executive Associate Dean for Research Affairs at the School of Medicine. She's chair of the Department of Medical and Molecular Genetics, and she's Executive Vice President for Academic Affairs for Clinical Research. I think I'll just stop there. That's just the first three. We could go on. But Tatiana, I was hoping maybe you would just give a sense of what is the Precision Health Initiative. And I mean, this is not only the universities, but I think the School of Medicine's largest research investment. And maybe you'd like to say something about why these areas.
Of course. So I'd love to. So we're giving you all a little bit of background about why Precision Health Initiative was put together and what its priorities are. So I feel maybe a bit privileged and sort of at the nexus of this. As a geneticist, precision medicine is thinking about how can we apply aspects of genetics and other kinds of new technologies to really try to improve care and develop cures. And one of the things that was originally set out within the Precision Health Initiative was a focus on genomic medicine. So again, thinking about genetics and how can we use genetics to improve care. We also have something called chemical biology, so thinking about how to develop new drugs. And then we also have another, if we can call it a pillar, which is around cell and immune therapy. And these things really flow together. You need to understand what could be wrong in terms of genetics. You want to use that in order to be able to think about how can we develop treatments. And then we need to think about how can we potentially administer those treatments. So that's the way I think about us, working our way across sort of three of the main areas. Really audacious goals initially one of them was to try to cure a childhood cancer. And so we're not there yet. And I want to say that I say that with real sadness, because I think if we had been able to get ourselves toward that and to achieve that goal, we'd be having a different conversation today. But I think what's incredibly important, and that I just want to always stress, and I think people increasingly are seeing sort of in our world the importance of research. The only way we can develop new treatments is through the participation of families and individuals who are sort of in the throes of diseases and willing to not only have their own pain and tragedy doing that, but also are willing to contribute and help others. And that's one of the things that I think the Trent family, you've really shown and really demonstrated for all of us, is the ability to help others see, walk with you on that journey and see the importance of research, and that sometimes it may not help in the immediate, but that you hope it's going to have an impact in the future. And I think that's a lot of what we're going to talk about today, is how do we work ourselves toward the elimination of a childhood cancer. And I think, I don't know if that's where you're going next, Fred, is maybe to get ourselves toward a little bit better understanding of what is pediatric sarcoma, and sort of start ourselves there, because I think that's a key part of understanding the importance of this mission.
Excellent. And let's just go right there. So Jamie and Karen, and I hope all the doctors are okay with my using your first names. It's much simpler and resolves the question of which doctorates count in this world. Maybe you would tell us a little bit about both. What are we talking about here? What are these childhood sarcomas, and why are they so challenging? Why don't we have better treatments and cures yet? Jamie, do you want to start?
Sure, absolutely. So sarcomas, and specifically here, we're focusing on childhood sarcomas, really encompass a variety of bone and soft tissue cancers, right? So cancers that originate in bones and soft tissues from a cell related to one of those tissues. So they include things like osteosarcoma that Tyler was diagnosed with, as well as the other two most common sarcomas are called Ewing sarcoma and rhabdomyosarcoma. But there are a variety of other childhood sarcomas that are less common. And you're right, they are very genetically diverse tumors, and in the case of osteosarcoma, pretty genetically complex, and respond to a variety of different kinds of treatments, right? So we think about cancer, treating cancer with medications and local control, so things like radiation and surgery to either kill tumor where it's living or take a tumor out. And unfortunately, with the sarcomas in particular, while outcomes have improved since the, say, 60s, we're still plateaued and really have plateaued over about the last 30 to 40 years, with curing between 65 and 70% of children with sarcomas. We're beginning to understand certain factors, molecular factors, genetic factors that may greatly increase risk or be protective. But as we learn more and more, we're beginning to understand unique ways to use some of the newer medications that are out there, more targeted medications, to really focus on what's driving individual tumors. And that's a complicated process, especially when you're thinking about childhood sarcomas, where within the state of Indiana, we really have only a handful of those tumors every year. So we're learning as much as possible from as many tumors as we can get our hands on.
And do you mind just saying a word about how you got into this area? I mean, clearly this is a important, it's intellectually demanding, but it must be a very emotionally demanding area as well to work in.
Yeah, you know, I love taking care of patients. I absolutely love interacting with families. It's a really, it's such a privilege to walk with a family through the process of experiencing childhood cancer, regardless of the outcome. And I never really saw myself as developing a research career necessarily. I love the idea that pediatric cancer and pediatric oncology in general involves so much research, because we as a field want to try to improve outcomes. And then I realized that I can hopefully have a greater impact on kids, families, and the broader field by trying to dig into some of the hard questions. You know, I'm not the lab expert, and I it's wonderful that we have a great team of people working together, because together the work that we can do is so much richer and can hopefully really move us in that direction. But so it really comes for me in a from a place of wanting to help improve lives of kids.
Yeah, well said. So Karen, you're a key partner on this team. Tell us what it is the Grand Challenge is actually trying to do in this area.
Yeah, I think that Jamie and I were kind of like poised to enter the Precision Health Initiative. We had been working together several years, had gotten some funding to kind of get the program going. And, you know, back to what Jamie said about the team that we have in place, it's a large group of people that, you know, Jamie and I are representing today. Everyone that works in the operating room, the surgical staff, the nurses, the technical staff, the pathology department. We have a biobank, we have a coordinator, we work with the core facilities and the IU Simon Cancer Center. All of this is involved to kind of develop this pipeline of tumor models that we have developed over the last 4.5 years. And I think one, you know, so a lot of things kind of contributed to us getting to this point. But, you know, back to what, you know, Jamie has said too about digging deep into the research, one aspect of this research is we need better models. And the technology now is at that point where, you know, we want to make models that are relevant to the patient population. We don't want to work with cell lines that have been grown in a plastic dish for 10 years. They still have merit. They can still be used for a variety of things. But a couple of things just to point out with not getting too nerdy about science stuff, but is, you know, a critical feature of these models is that the tumor specimens that we get, these of course are de-identified. We do not know the patients over here in the Wells Center. There are occasions like Tyler where he was of age and his parents also gave permission that we can break the code because he was very interested in what happened. So occasionally that happens, but most of our cases are anonymous. We do not know who the patient is. But we get these tumor samples, we can put them in mice, and so they're never put in these plastic Petri dishes or flasks. And so one of the manuscripts we're working on right now is actually digging in deep into these molecular signatures. And do they stay the same when we grow them in the mice? And overall, we think they do. And so the first thing is developing clinically relevant models, understanding the mutations and pathways that are dysregulated in these models. And then through the Precision Health Initiative, having the ability to link this with the patient data. And so the way we have our xenograph pipeline set up, we can, through our clinical folks, go back at another point in time and say, what happened to this patient? So it's really critical to know how the patient was treated up front. We make a model, and then what happened to the patient later. It's all very critical in integrating, linking the patient data and the research data. And the last thing I'll say is that back to this modeling approach. So we've been able to make these models, we can grow them in mice, but what we're doing now is absolutely critical to the next part of this program, and that is to develop metastatic models. Unfortunately, a lot of these kids die from the metastatic disease. That's the disease when the tumor spreads to other parts of the body. And so we think we've got a couple tricks up our sleeve how we can take some of the models that we've made from pediatric patients and young adult patients seen at Riley and develop not only these primary models, but also models of metastatic disease. So the modeling is critical, and it's critical to link it with the patient data.
Okay, thank you. And thank you for keeping that in understandable terms. That's why I get invited to moderate, because they're like, if I can understand, anyone will be able to understand. So if we could turn to the Trents, Kelly and Tony, if you don't mind, just start us at the beginning. Like, you first got a diagnosis. Tell us a little about your journey and of course, Tyler's journey.
Yeah, sure. So Tyler was first diagnosed with osteosarcoma bone cancer in July of 2014. It was on his humerus bone and had grown into his shoulder. And just went through the protocol, the very traditional form of therapy that is used for that. And kind of like Dr. Renbarger noted, that therapy is about 30 to 40 years old. There just really hasn't been anything new since that. And so he had that and then went into, I believe, about 15 months of remission. And then just before he graduated high school in the spring of 2017, it had come back and he had a tumor in his hip pelvic region. And at that point is when Dr. Renbarger got involved in the genomics department, and we did all of the testing with that and came up with a new course of treatment. And so, and with, at least I know with osteosarcoma, it's the combination of medicine, surgery. It requires both for the possibility of a cure or survival. And so we started some of the genomics treatments, and then he had a massive surgery at the end of that summer in 2017, and then continued on the genomic oral drugs. And then in the spring of 2018, it came back again, and it was on his spine. And at that point, it was inoperable and considered terminal at that point. We did try some other combinations of possibilities that we had they had come up with in regards to the genomic testing that they had done. But he, and he did live, he was given about 2 weeks to 2 months in May of 2018, and he did live until January 1st, 2019, when he lost fight. But that fall in 2018, he, like I mentioned before, his drive really did revolve around at that point about leaving a legacy and wanting to really do that within the cancer community, and not having other patients and families go through what he did. And he recognized too what our family did. And, in order to do that, there needs to be new testing and new techniques and new drugs and living tumor cells in order to test that on. And he really wanted to be a part of that. And it became very near and dear to his heart. And he was so honored to be a part of that. And I think too, with that, wanting to be an example for other patients, to kind of be, to speak about that and the need for that, and to hopefully encourage other families and patients to do the same thing, to donate and to be a part of that. And, Riley, it is true. They become like family, the doctors and the nurses. And we have been so blessed and so privileged to have gotten to be this hands-on with it all, and to feel as if we're able to continue that for Tyler, and to be a part of that, and to do what we can, whatever we can, to help bring awareness and encouragement for other families, and whatever we can do, for the doctors and the limited knowledge that we do have. But we're just honored to carry that on, and we're thankful for Riley and Dr. Pollok and Dr. Renbarger and the whole everyone, just for what they've done for our family to allow us to be a part of it.
Well, thank you. And let me say also, just thank you for your willingness to be here and share this story. I know, despite the enormous courage that you all have shown and the incredible leadership, it must still be painful. And so we are really grateful for your willingness to share. Tony, it looked like maybe you wanted to say something there.
I just want to speak from a father's heart. And we'd never been to Riley Hospital before, until we had Tyler get sick. And as Kelly mentioned, the doctors, the nurses, the team is just extraordinary. And as Jamie alluded to, the technology, you walk into a state-of-the-art medical facility, and you don't, at the time I didn't realize that, there isn't a better treatment for my child. And I think that's the tragedy. And I think that's the purpose of a grand challenge, right? I mean, you have a child who is really sick and we need help. And if the process, you know, I have a 60% chance that my child is going to make it. And if it comes back, that percentage is pretty much zero from what I understand. And so we desperately need new technology for these kids that seems to be getting more and more prevalent with these illnesses. And I often ask somebody, the question is, if you were to go buy a car that's 30 years old, you know, would you feel safe in it versus the technology that you have today? And so my plea is that we can find a way to get a cure through research for other families so they don't have to go through the amazing, painful journey that it is.
Wow, exceptionally well said. And I think you will find you have many of those friends and caregivers from Riley who are watching today, and I know they'll appreciate your words as well. I might just ask Karen and Jamie, if you will, just say a moment. What difference has the Grand Challenge made? In other words, you were already remarkable physicians and researchers prior to this. What are we doing to get closer to the vision that the Trents laid out, where we'll be using more successful and more modern treatments? Is the Grand Challenge helping do that? And what else can we be doing?
Karen, you want to start or you want me to?
I think you should.
Okay. So, you know, I think, first of all, I think the Grand Challenge really for us provided a foundation of not only support, but also a rapidly developed infrastructure around our team that allowed us to do work by bringing amazing people together that I think otherwise would have taken years to put all those pieces together for us. And so without the support of the Grand Challenge, we would not be where we are today. You know, Karen talked about the number of models that we've developed.
Right.
That was so critical to the work that we're doing and required, you know, as she talked about, connecting with the operating room personnel and the surgeons and not as clinical colleagues, which they're wonderful clinical colleagues, but really to do science because everyone is such a critical part of this really complicated continuum. And without that support, there's no way we would be where we are today. And within, you know, you would talk to a medical oncologist, an adult oncologist, as we pediatricians say, and they would say, models, we have models coming out our ears, right? I mean, we don't, right? Within pediatrics, because these are rare tumors and because when cancer relapses in a child, 5 to 7 years ago, it was pretty rare to even rebiopsy that tumor. Right, we would empirically start some traditional relapse chemotherapy or salvage treatment, and things have changed so dramatically, which not only have allowed us to make more informed decisions about treatments at relapse, which is scratching the surface of curing, but really to develop a research infrastructure that is really allowing us to really take off and move towards better outcomes. And the last thing I'll say is that the opportunity to connect with not only Tyler and his family, as well as a number of other children and their families around this common passion for we can't be satisfied with where we are. We have to do something. And by bringing everyone together, including the passion and the heartfelt pleas really of families, I think has, as Karen mentioned, has really energized our team in a way I've never seen before. It's a really special part. They are a very special part of our team now. And that's incredible. So.
Yeah, that's well said.
Go ahead, Karen, yeah, please.
Okay. Yeah, I just add just a couple little points to that. You know, Jamie talked about the number of models too that we've been able to make, and we had some funding through the NIH, you know, to develop some models. And at that point, when we got that, we're like, well, maybe we'll be able to develop a handful. Maybe if we'll be good to get 10. You know, these are samples that they're actually, because of the chemo that a lot of the kids have been on, they're highly necrotic samples. And so the one thing that, you know, I'll say from the research standpoint is we have to be brave enough to fail in our research. And that's only the way we're going to push the envelope on this, is that we can't be too timid. We have to have rationale for every hypothesis that we generate, but we've really got to start pushing the envelope a little bit more. And what the PHI has allowed us to do in our lab is to really push the envelope more and see, you know, it's as important to know what doesn't work as what is going to work. They're both very important. And in science, you'll hear there's negative data and there's good data. The negative data, if it's done correctly and with rigor, it's extremely important to know what doesn't work. And so we try to have that philosophy in our lab. It's like the data is going to guide which way we're going to go, but we're also going to push the envelope in what we're looking at as far as new therapies in these models. So where we thought we might have 8 or 10, now we've got over 40 models. And so the PHI has been critical, as Jamie said, in developing the infrastructure.
You make such an important point, because, you know, many people often ask me as Vice President for Research, why is research so expensive? And of course, research wouldn't be expensive at all if we knew what the answer was, right? We would just implement the answer. You wouldn't even need the research. But it's all the things that don't work that we have to figure our way through and use those to build on to create a solution. Similarly, I just wanted to reflect for a second on Jamie's point, which has been so critical to the grand challenges, and that is the importance of recognizing how much help we need from others. Universities are sometimes described pejoratively as, you know, ivory towers, or, you know, we think we know best. And I think one of the things we have all learned in the research space is we're not going to get to any solutions without the help of lots of others. And that includes, of course, families like the Trents, and, you know, patients like Tyler. It includes, you know, funders who fund from the federal level and the state level, and philanthropic donations. It includes the partnership between institutions, because, you know, as you all noted, we don't even fortunately have enough examples of certain of these types of sarcomas that we need to work with others. And I think one of the things that has come with the grand challenges has been, ironically, a little bit of humility about how much we depend on people, Kelly and Tony being perfect examples, but such a large web of people and institutions to make progress on these challenges that we all face. And so again, it's a chance to say how much we appreciate what you all have done, and certainly what your son did during his life, to make this point so clear to others that this isn't something that's going to come down from Mount Olympus. It's something we're going to find a cure, but we're going to find it only by working together. And so we're enormously grateful from that. Tatiana, you looked like you had something to say, and I want to get out of your way so you can say it.
No.
Let me also say, people can post questions. I'm not the only one who gets to ask questions. So there is a Q&A button on your screen. And if you want to ask other questions, Christine Drury has shown up to make sure we don't ignore those questions. But Tatiana, the floor is yours.
Oh, I was just going to add, sort of along the lines of what Karen's mentioned, which is the whole question about having negative data. I think the other thing is, for those of you who know what the National Institutes of Health is, so it's our government supported entity that supports research. One of the the hard things about NIH funding is it's, of course, key to research, but it is a little bit risk aversive. And so sometimes, if you go back and look at some of the major discoveries that have been made, they're not always funded by the NIH because the NIH isn't necessarily looking sort of at the cutting edge. And I also see that as a critical part of the PHI, is that whole idea of being able to take risks. I think sometimes it gives you negative answers, but that ability to also do things quickly. And so, families can't wait. They really need things to move. And NIH works from idea to getting something funded could be anywhere from 18 months to 2 years sometimes. And so really, that's one of the really key things about PHIs. It's given us infrastructure and has also given us the ability to do some risk. And I think that's really important and a key thing I just wanted to also highlight.
Well said. Well said. Kelly, Tony, if we can just turn back to you for a second. We talked a lot about Tyler and the role he's played, and of course his own encounter with disease. I just wonder if you'd like to take a moment and tell us something else about Tyler that's not related to sarcoma. Something, I see the jerseys behind you. Tony, you were mentioning about going to the race. Anything you would like to say about that?
Yeah, so Tyler was an extraordinary young man. Ever since he was a little kid, people would come up to us and say, man, we can't wait to see what this kid does with his life. We just never dreamt that it would be like this. But he was one of those kids that got nicknamed in school as Smiley. He always smiled no matter what. He had such a positive attitude on life. He loved sports. He was competitive. He was really smart. And he wanted to make a difference with his life, regardless of where he was at. And I think there's a lot of important life lessons that you can learn from his life. And I think one of the most important ones that he's taught me is that he bloomed where he was planted. And I think in today's world, we always blame it on circumstances. And I think that no matter where you're at, you can make a difference in your life if you just approach life the right way. So bloom where you're planted would be something I would encourage people to consider.
Yeah, and one thing I would like to add to that is to go back to when in May in 2018, when they guessed around 2 weeks to 2 months. We didn't tell Tyler that because we knew who Tyler was and his wiring, and we just didn't want that to hold him back. We wanted him to be able to live his days not thinking, he had a time limit on that. And it's so amazing to me and fascinating all that happened between May of 2018 until he passed away. And really everything we're talking about today, it really, really came to a light in the fall of 2018. And I'm so grateful that, it's not a coincidence, that it happened like that. And that he was able to, that his heart was to leave a legacy and drive research and bring awareness. And it really was that he was given the time to be able to do that, because it was in his last days that really happened.
Right.
And if I may add to just one important thing about research, Tyler was all about research all the time. He was a researcher. But I think even after Tyler passed away and we discovered from his tumors that if we were to use a different drug combination or taken one of the drugs away, I don't remember if it was methotrexate or cisplatin or doxorubicin, but with his tumor, if we would have taken one of those drugs away, we would have found that the therapy may have been better for him. So that's why research is important, because we can't figure that out without research. And we want, like we said, we don't want other families to endure the pain that comes from losing your firstborn son, but also the havoc that it plays on your family when you have to walk 5 years living in a hospital and seeing what the drugs do to your child. It's heart-wrenching.
I can well understand. And can we just talk about that research and that legacy just a little bit longer? So how did this first come up about his participating in research? Did someone at the hospital raise it? Was it one of the doctors, or did you all raise it?
I don't know if I recall exactly. I think the hospital may have came to him and asked him if he'd be willing to donate his tumors. And he said, absolutely. Anything I can do, because he was a very perceptive child and he saw what had happened to our family. And he understood the importance of research, and he understood that it's not possible to find a cure without research. I mean, we can use, from what I understand, breast cancer has gotten a ton of research. It's got it funded very well, and they've made huge strides in breast cancer. And so we just, again, it's so important to research.
Well, and I think, and it wasn't just for Tyler, it wasn't just donating, the cells and the tumor. It was then, I want to know what's going on. I want to be involved in the process. And he even, when Dr. Pollok and Dr. Renbarger were at our house in that fall of 2018, he was like, you want this one? You want that one? I mean, he just wanted to give, he was offering up his body basically, so that they could, but that's just where his heart was. And so for us as parents to be able to continue to be involved and bring awareness, and like I said, do anything that we can, it's a source of comfort and healing.
Well, and as I think a number of people have already said on this call, those donations have had an extraordinary impact. I mean, they are having an extraordinary impact. And so it is a lasting legacy. And of course, the other work that you all have done since losing your son has been extraordinary. And so again, I know I speak for us all and many people on the call and saying how much that's meant. Tatiana, can we turn back to you a second, because you oversee the entire Precision Health Grand Challenge. And while this is the focus of this particular conversation, I just wonder if you'd like to say a word about the bigger picture and other areas in which maybe we are also making progress.
I'd be glad to.
I feel like we may have temporarily lost Tatiana, either that or she's mesmerized by this and is just giving it exceptional thought. But while we're waiting to get her back, let me just ask a question about particularly to Jamie and Karen. So then this work, of course, you've been working at for years, but for the past 18 months, you've been also having to deal with COVID while doing this work. And I wonder if you just care to say a comment about how has that affected this work? Has it continued unabated, or has it posed a particular challenge?
So, I definitely want to touch on that. And before we do, I just want to throw at one point connected to what Kelly and Tony were saying and your comment in response to that. I think one of the things, even to this day, that we're seeing that has just amazed me is an interest in patients and families wanting to donate tissue for research, really based on what they know about Tyler, right? And what they have seen in the news about Tyler and even some of his words. And so and as recently as just a few weeks ago, from a family getting treatment in Cincinnati, who have a young adult son, actually was the son really, who I believe is a student at IU in Bloomington, who is suffering from relapsed rhabdomyosarcoma, so another kind of a sarcoma, and wanted to make sure that something happened with his tissue from a research perspective, to really help so that other young adults and teenagers and children don't have to go through what he's going through. And through amazing collaborative work between University of Cincinnati and IU, we were able to make that happen really, really quickly. But it was clearly Tyler's legacy that had a profound impact on this young man, and in his desire to continue to find ways to improve outcomes in kids with really aggressive sarcomas. So, I expect that we'll continue to see more and more of that, and hopefully in a broad way. The other piece that I want to touch on, and sorry, I'm not directly going to COVID yet.
It's all right. I'll get you there.
But the other piece is that, while we're developing these models here, those aren't models that we're saving in a little,
Right.
lab for ourselves, right? This is a resource for the broad research community, scientists anywhere. And so Karen and the entire team have put an incredible amount of work into ensuring that we have high quality models. And so again, our hope is that over time, more and more people will continue to take advantage of these, so that we can really exponentially expedite the work, or the work that we're doing. So, and finally, COVID, and Karen can definitely address this really well. COVID has introduced a lot of challenges for us, for sure. I would say much of the work that we have ongoing, while it certainly wasn't happening quite as quickly, and with having to rotate people in the lab, given that we were developing in vivo models, and that a lot of this involves patients and is very tightly linked to patient care, we never screeched to a halt. But we're certainly had a great slowdown, and then and things have really, I think, ramped up in a great way. And Karen can add a lot to that, I'm sure.
Yeah, I'll just add just a couple of points to that. Because of the core facility we have in the IU Simon Cancer Center, it's called the In Vivo Therapeutics Core. That was deemed an essential core. And so the personnel in that core, even though it was still staggered, could continue to work. And so we actually were still doing studies on Tyler's model and several other of the osteo models during that time. So we didn't completely come to a halt, but it's definitely been a challenge too, with supply lines, things you need to get and all that. I did see a question pop in there that maybe I should go on and address.
Go right ahead.
Someone was asking how the models are utilized. And just real quick on that, it's a great question. So the models are utilized, number one, to understand the molecular signatures, make sure they are similar, if not identical, to the original patient sample. But then we can test novel combination therapies in these models. So therapies that there is rationale built on what we learn about the precision genomics or the molecular signature, and then we can test these therapies in the mouse models, and we can test if these therapies are toxic. We had one this past week where we started pushing the envelope, and we had our drug doses too high. So we do a lot of rationally designed but exploratory work in novel combination therapies using drugs that are fairly new, and they're targeted agents.
And that is, maybe you could just help connect this just a little more clearly
Sure.
the non-medical people in the world, from the donation of Tyler's tumors to the development of the model to this progress that you're making?
Absolutely. So we published last year in the journal called Cancers on a therapy that targets a process called replication stress. And this is a dysregulated network that Tyler's tumor certainly had, and a lot of the osteos have that. So when we get a tumor, it comes from the OR, it's processed in the laboratory, and then within a very short period of time, try 3 to 4 hours if we can, the tumors are actually implanted in a mouse model. It's an immunodeficient mouse. So you can grow human tumors and such in these because they don't have a working immune system. Now, the downside of those models is that this tumor microenvironment may not be exactly what you would see in a patient, but you can capture the molecular signature of these tumors. And so we get in the research lab, this has this highly regulated work. So the tissue that we end up with, we can't take tissue that's going to need to be used, for a diagnostic standpoint, or that's going to need to go to a clinical grade sequencing facility. That is priority. So the tissue we get a lot of times is pretty small. And I actually still remember when we got Tyler's tumor in that August of 2017. We didn't know it was him, but we had some folks on vacation, and I don't think I've ever told Kelly and Tony this, but I ended up over in pathology because of this case. And I remember on that one, we brought it back and I was like, gosh, I don't know if this one's going to grow. It's really small. They couldn't give us too much, all these things. And I remember actually Tony Sin, one of my great colleagues, was in the hood, and I said, we just have to go with it. We just got to go and put it in. And then it's just amazing. We talk about that story some, like, thank goodness we already, we did that. We had one already from the May 2017 sample, but this was the August, and the August 2017 sample has ended up being one of our really best models in terms of how it behaves, and it's very consistent, and you can really test novel combination therapies on it quite well. So, Tyler gave us a gift in many ways. He helped us actually optimize our pipeline as well. We've learned so much on how to manage the pipeline and set up the studies from that one sample. It's just incredible. So that's in a nutshell. Lots of understanding the genomics, prioritizing what the clinicians want to see, where there are opportunities of unexplored research. And replication stress is a big network that we study in osteosarcoma. Unfortunately, that cancer doesn't have what you call a main driver of the cancer. There are many drivers of that cancer. Wow. And so it's a real chaotic one in terms of its genome on how you have to study it. But we actually now have, I think it's at least 18 aggressive osteosarcoma models. It's been one where there's been a lot of activity over the last 4 years. And I think part of the reason these models take is because they are so aggressive. So we get tissue, routinely that does not work. So we're about 40 to 50% on our take rate in terms of actually being able to develop a long-term model to study.
Right. All right. Thank you. So Tatiana, let's try one more time and see if your computer, I know it enjoyed you being on vacation too.
It did not.
Tell us the rest of what's going on quickly, I'm afraid.
Of course. No, I will be really fast. And there was one other question in the chat. I don't know if we're going to get to that. So but I think it's an important one. So I would just say the other areas that we've had quite a bit of research ongoing is multiple myeloma, also neurodegeneration, have had quite a bit of work on gestational diabetes. And perhaps in the future, we'll also talk about what we've done around an undiagnosed rare disease clinic, which has some real parallels. It's families coming in, not understanding what the diagnosis is and using genomics to get there. Can I just tuck in, Fred, if I can? So the question in the chat, and I think it's a real compliment to what we talked about a lot in the last Precision Health Grand Challenge webinar, which was triple negative breast cancer, which disproportionately affects African-American women. And so there's a question around ensuring that, I think partly, are there any disparities in terms of these childhood cancers? Is it more common in individuals of certain race or ethnicities, and are all families able to access and be part of the pediatric sarcoma efforts? And I'll turn that over to Jamie and to Karen.
Sure. Yeah, so we do approach from a relapse cancer perspective every patient with relapsed cancer to participate in our Indiana Pediatric Biobank, which is a partner biobank with the IB or Indiana Biobank, which allows us to collect fresh tissue specifically for research and for development of models. We've also moved to approaching newly diagnosed patients as well. We're not doing that across the board yet, and that is not every disease type, but certainly every patient within specific disease groups, particularly the sarcomas. In terms of racial disparities in diagnosis or aggressiveness of these sarcomas, it really represents the general population. So there isn't a predilection for relapse or aggressive sarcoma in Black patients, for example, or Hispanic patients. So we, again, we include everyone who will consent.
So let me jump in here to say, unfortunately, our time has sped away as I predicted at the start that it would. I want to take just a moment to thank once again Dr. Karen Pollok and Dr. Jamie Renbarger for your remarkable work, for your expertise, your dedication, and of course for this amazing research that you lead. I'm so grateful as always to Tatiana Foroud, who leads research throughout the university and is playing such a critical role in leading this grand challenge. Christine Drury and Lisa Fukuda help organize events like this, and we're extremely grateful to you and your teams for making it possible. And then most of all, again, to the Trents, Kelly and Tony, we so appreciate your time with us today. We appreciate the much larger commitment you've made in this area and the way in which you and Tyler continue really every day to give life to his legacy. We are so grateful for your being with us today. To everyone, I hope you have a good week. Thank you for joining us. Bye-bye.